I read the newspaper, I'm a patient. I hear that there's GLP-1s and DPP-4s and SGLT2s, and the paper says they're great, and the paper that I read, I believe, I want it. Why shouldn't I have it?
Yeah, but I think it's always nice to really document the feeling that you might have. I mean, yeah, I mean, we really, obviously, cardiologists more than us are very excited, and they want to treat their patients before they get any cardiovascular event, such as heart attack or need stent or bypass. But I think we'll have to do those kind of studies. Already there are studies in progress in people without diabetes who have a high risk of heart failure, or who already have heart failure, and we want to prevent the further episodes.
Okay.
So those kinds of studies are currently in progress. Okay. So we really can't, I mean, amidst all our excitement, we still need to wait for some of those studies to be completed, and several of such trials are continuing. And you might raise the question, what about people without diabetes with kidney disease? Now that comes up as the next question. And I think
because he's not going to improve it, that's why.
Well, we have to, our job is to convince him eventually, right?
Well, are there studies? I mean, okay, I come to you. I've got a patient with kidney disease. These drugs clearly, in the diabetes studies, show a desirable impact on the progression of renal failure. Can I have it if my patient doesn't have diabetes?
Well, it's a good question.
Deathly silence here.
Yeah, well, it depends on the design. In some cases, if there's a prior auth on it that requires diabetes as the indication, then you're going to get an initial no. And then the physician has to make his or her case to say, we want to use it in this particular patient with chronic kidney disease because here's the data to support that. And if they make a good case, typically, you do get coverage.
And that's what we need to do, Jim, because I think we should really be looking at the long-sighted view, not the short-sighted view of just controlling the proteinuria or controlling the blood glucose. And you know that you will be saving a lot of money by paying a little bit ahead and preventing these complications,
He's
dialysis,
make his fourth
transplantation.
Well, you got to make Q4.
You hear a lot of
commentary. That's been ongoing for years, right?
Absolutely. You hear a lot of commentary on our side. Well, we don't want to treat the patient today because that complication is not going to occur for 20 years. That's a bunch of baloney.
But if we can tell you which one out of those three people will get kidney failure.
Right, but if you think about it, if we treat everybody the same, when the patient switches health plans, Helena's still her doctor. So she's still treating her the same way. So if we're sitting there saying, well, we're going to try to exclude this coverage or not allow access to these drugs and so forth, makes no sense. You want to use the best choices. You want to use the most cost-effective choices from the plan perspective because we don't have unlimited resources. And then when we start to see the positive results, it's also incumbent on the manufacturers to come in and share that information, get that clinical information to us sooner so that we understand the potential additional role of these drugs, and maybe we'd be less restrictive.
All right, let me mention something so horrible that I'm almost going to have to whisper it. If you're telling me that all the plans have to have the same criteria and have to pay for the same drugs, why are there different plans? Why not just a single payer?
That's one for the politicians.
I tried.
I'm not going to touch that one.
Thank you for doing that.
I mean, what you're really saying is there's no uniformity across plans, and that's
well,
a
there
problem.
isn't, but there's also not uniformity around the country. You have different practice standards, you have different, preferences among different categories of drugs, and when you think about, you've got 4 or 5 different categories of drug or therapeutic classes of drug within diabetes space. It may be very different practice in California than it is in the Southwest, than it is in the Northeast. So that makes a big difference as well. There isn't universal consensus, and then the pricing is different, right? If somebody gets a drug on formulary on Plan A, then the company that lost out is now going to competitively bid to try to get it on Plan B. So now you've got 2 different drugs, 2 different formularies, because everybody wants a piece of the business.